Geriatric Physical Therapy, Chapter 30, Reimbursement and Payment Policy. We're going to discuss healthcare and access to healthcare. The Patient Protection and Affordable Care Act, also known as Obamacare, was signed by President Obama in March 2010. This allowed access for all Americans to begin having health insurance. The enrollment began in 2014. It wasn't always the easiest website to access, but it did allow more Americans to get health care than ever before. Since then, we've seen quite a few changes, some things that have been removed or taken out, and then newer administration wanting to revamp it altogether and or get rid of it. But for the time being, it's here to stay. The other thing that was established in 1965 was Medicare, and that was the ability for adults age 65 and older to gain health care access. There are a couple different distinguishing features. Medicare Part A covers any hospital-specific care. Medicare Part B covers any physician services, including physical therapy services, outpatient kind of services, that sort of thing. So it's an additional kind of rider on the plan. So they have the Medicare Part A that covers hospital care and Medicare Part B that covers most all other services. So some home health, some outpatient, physician services, etc. And then Medicaid was also established, and that's a federal and also a state-funded program that covers low-income adults. Those that are also disabled can apply for Medicaid as well. And that allows for similar type services that Medicare does. But again, with all plans that are out there, not every healthcare provider accepts all plans. So when patients are shopping around and looking for their healthcare provider, they have to ensure that their plan is covered by the provider that they want to see. Funding for these healthcare services. Originally, the healthcare services were paid based on the number and type of services provided in both the private and then also the public sectors. Back in 1983, the prospective payment system for hospitals was put into place. Essentially, whatever was done by the physician or other healthcare provider was billed out specifically for that. So, service, kind of a fee-for-service kind of adjustment. In 1997, the prospective payment system was also put in place for the skilled nursing facilities and home care services as well. The instruction was to provide care in a cost-effective manner. That was the initial plan, because the payment for admission will essentially be the same. So I thought they'd kind of level out the playing field and keep the costs down. In 1997, the Balanced Budget Act came in specifically for Medicare recipients, and there was an adjustable fee schedule conversion, and this tried to control costs. Back in 1997, when this was put into place, the goal was to adjust for various factors, including inflation, those sorts of things, to determine what the payment would be for the following year. And we'll see that there have been some issues and pitfalls that came along with that initial legislation later on in the discussion here today. So definitions of insurance, and you all might know most of these definitions, but keep in mind that just because you understand them doesn't mean that most of your patients will. So sometimes when it comes to taking care of our patients, we have to define and explain what some of these definitions actually are and what they truly mean. And not that you have to understand all of them, but it's good to have a nice understanding. Number one, for you as a patient to understand what these things actually mean, and number two, to help your patients understand them better, or to find the person in your facility that can help them understand what these definitions mean. So speaking in terms of talking about the premium, that's going to be the monthly payment that's paid by the patient to keep the insurance. Just like any other premium that we have when it comes to car insurance or whatever, it's the same thing when it comes to health care. So there's usually a monthly allotment that needs to be paid out to keep that insurance active. Next is the deductible. That's the patient's portion of the payment that must be met prior to insurance paying their portion. So when I started in the therapy world, we would see a lot of patients would have a deductible somewhere in the range of $250 to right around maybe $1,000, and $1,000 would probably be about the max that I would see back then. But that's changing drastically. So when it came to that deductible, if somebody had, say, a $250 deductible, they would have to meet all of that. So whatever bills were put out towards the patient, they would have to pay the first $250, and then their insurance would start to kick in based on the rest of the plan that was set forth for them. Now, to see $500 or $1,000 being a deductible is considered extremely low. Most patients' deductibles are anywhere from $2,000 to $5,000, and I've even seen a couple $10,000 deductible plans. Again, that's not right or wrong. Sometimes there's ones that make sense for patients that maybe they're paying a lower premium, but in response to that, they have a higher deductible, so they're going to be paying out more throughout the year. These plans might be good for somebody that tends to be generally healthy. So if you don't go to the doctor much and you only maybe go once for your kind of annual physical, then maybe there's not much you're going to have to pay out of pocket, but keeping in mind what that looks like for patients. Some patients will choose plans just based on the premium, so it looks pretty low per month that they're paying, but they're not looking at the full picture to see what it actually covers. The next thing is copay. So the copay is a specific dollar amount that's paid for a specific service. PT tends to fall in this realm, so do physicians' visits a lot of times, and there might be a specific dollar amount that the patient has to pay, and they're going to have to pay that every time they go in for that service. So for PT, if you're seeing a patient twice a week, then they're going to have to pay that copay twice a week every time that they come in. Usually at most offices, they won't let you back to see the physician or the PT or whatever healthcare provider until that is paid up front, and then you get to see your provider. I've even seen that copay go up as high as $70, $75 per visit, which is a lot of money for some patients up front when they see that, and so that can be a bit of a sticker shock. So not that we're not worth it, and we need to make sure that we realize that we are, but just knowing that there's a lot more that patients are having to pay out of their own pocket to get the healthcare services. The next thing is coinsurance, and that's considered to be a portion of payment for services provided. What that means is once the patient hits their deductible, so say that $1,000 mark, now their coinsurance goes into effect. So if they have, say, a $1,000 deductible with a 20% coinsurance, once they've met the $1,000 deductible, now they're going to have to pay 20% of the allowable amount. And each insurance can determine what their specific allowable amount is. So every plan can be different. Even, a Blue Cross Blue Shield plan, 3 different employers might have 3 different plans. So you can't make the assumption that just because somebody had Blue Cross before and now they've got a new plan with a different employer means they're going to have the exact same plan. They can vary very widely across the board. Visit limit. So this is the next thing that is important to note. Sometimes this can be an annual visit limit. We're seeing a lot more of these again, or per condition. I've not seen a per condition limit in a while, but people need to understand what their plan actually covers. It's nice if providers actually let patients know what their plan is, but it really is up to the patient to understand what their plan actually covers or doesn't cover. I don't see this as much now, but I have a feeling in the future we might see this again. But when I first started out in the PT world, we would have some patients that would have a $20 per visit limit for the life of that insurance plan. That is 20 visits regardless of how long they stayed on that insurance plan. Now, assuming somebody left that company and went to work for somebody else, then they're fine. Now they've got a new bucket to dip into to use. But making sure that you understand when it says that somebody has 20 visits, understand is that annually, is that per condition, or is that per the life of that plan that they have. So making sure that you understand that, especially if you're working with patients maybe in an outpatient setting and have to understand what their how many visits they have. If they've got 20 visits per year, you have to make sure they're using them wisely, especially if maybe they're a post-op patient. How long do we spend with the patient? Are we going to see them 3 times a week for 4 weeks? Now we've already burnt 12 of their visits. Making sure that we're having those conversations with the patient so they realize how we need to progress them, what that insurance is going to look like as far as how many visits we feel like we need to see them for. The next thing is Medicare, the therapy cap for services. Now that's changed over the last handful of years, and we'll discuss that in the next lecture that we have, Chapter 31, but just know that that was a way for insurance to kind of cut their losses and make sure that they could pay for the services that were being provided. And then cost sharing is another term that you'll hear, and that's just a way to control costs, and insurance has done that. They say it is a bit of a positive thing, and I don't think it's necessarily a bad thing, but cost sharing just means insurance might be paying less and the patient's going to be paying more out of their own pocket. And that has definitely swung more in the patient's direction, where patients are having to pay more for their healthcare services than they ever used to. So good definitions to understand. So again, with these cost controlling mechanisms, let's talk specifically about Medicare. When it comes to Medicare, because it is a government funded program, you have to have a budget neutral piece of legislation. So when CMS, Center for Medicare and Medicaid Services, start looking at their budget for the next year, they have to determine how much money is being paid into the system and how much money is going out of the system. And so there's ways that they have to control their costs. And so they need to make sure that whatever costs are going out, they're equating for in some sort of income coming in for that. So providers can choose what insurances they take. Now, as far as Medicare goes, at this point, physical therapists are not allowed to opt out of Medicare, so we are considered one of the providers for Medicare. So some physicians will decide that they don't want to take Medicare because of the rules and regulations that are attached to that, and every healthcare provider has that ability to choose who and what insurance they're going to take. And again, from a PT standpoint, we're legally not allowed to opt out at this point, although there have been discussions about putting forth some sort of legislation that allow PTs to opt out of Medicare. The next thing is utilization management, and that's just a fancy word for a whole lot more paperwork that we have to do, which can be a bit frustrating, but it is just sometimes a hoop that we have to jump through. So for some of our insurances, specifically for us in the outpatient world, United Healthcare is one, Humana used to be one, and as of 2020 it's going to become one again. There is more paperwork that's required. We have to go onto their website, fill out forms there, and request specific authorization. That authorization comes back to us and they tell us specifically how many visits were allowed. So even if the patient, like we talked about before, was allowed 20 visits per year, maybe their United Healthcare insurance comes back and says, we've approved 6 visits. Now, you can only see them for those 6 visits, otherwise you're not going to get paid for any more than that. Once they hit their 6th visit, you might be able to ask for more visits and get more approved, but you have to understand how that works. Benefit restrictions. So again, maybe they're only allowed so many visits per year. Maybe there's a specific dollar threshold that insurance says that we'll pay for $1,000 worth of physical therapy services. And so again, understanding that situation, or having the patient know what they need to do to understand their own insurance. Increased patient cost charging. So again, it kind of goes back to what the patients are responsible for at the end of the day. There might be limitations on covered services. So the big talk recently, at least in the PT world, is dry needling. There hadn't been a code for dry needling, but starting in 2020, Medicare does have a code now for dry needling. Although at the time of this recording, there is not a price associated with payment for dry needling. So even though there's a code for it, doesn't mean we're actually going to get paid for it. So Blue Cross Blue Shield's another one. When it comes to covered services, they will not pay for any sort of electrical stimulation, TENS unit, those kind of things. They deem them as experimental, and so therefore they're not going to pay for them. So every facility is different as far as what they're willing to do in that instance. So maybe a facility says, we're not going to do any of those services that are not covered, or the patient has to pay for those out of pocket. And then there's financial caps on services. Medicare specifically has been one of those, and thankfully with legislation we've been able to remove some of those barriers to allow patients to get the care that they need. So with Medicare, there's quite a few different options. We kind of discussed this a little bit earlier, but Part A is more the hospital services. It also does cover some skilled nursing facilities and home health services. There's usually no premium when it comes to Medicare options when it's in that Part A specific area, and daily rate's going to depend on the location. So if they're inpatient or acute care, they're going to get paid one rate. Skilled nursing is going to be a little bit different, home health different as well. Now, Part B Medicare services, that's for more the outpatient services and for some home health services, depending on how they're set up. There is a premium, so therefore the patients do have to pay something out of pocket when it comes to that, and there is a 20% co-insurance to the patient. Most of our Medicare patients do have a secondary insurance that will cover that 20%, but know that they do have that. Part B Medicare also does have a deductible, and so patients will have to pay that as well. As of 2019, I believe the deductible was $187 per year. So usually one visit to the doctor is going to be about $187, so they will have already paid their deductible the first time they saw the doctor, and then after that it goes into that 20% co-insurance. So usually as long as a patient has a secondary insurance, that might cover most of the out-of-pocket expense for the patient. The next thing is the Part C, and that's for fee-for-service. You don't see that a lot, but that is an option with Medicare plans that they could have a Part C. Part D, again, this is not something that we use, but it is a prescription drug benefit for the Medicare recipient, and that just covers, again, all their prescription drug costs. As with everything else, there are a ton of different Medicare Part D plans that the patient can choose from. It's really good for patients to work with somebody that understands the Medicare system to help ensure that they get into the right Part D plan. Again, if you have somebody that's relatively healthy, not taking a lot of medications, they might be able to go with a fairly low-level Part D plan. But if they're taking a whole lot of medications, they're going to want to make sure that they've got proper coverage for that. So ensuring that patients look and see what their plans are and what it specifically covers. It can be tough. Most of the time when they look at what plans they should be under, they're basing it off of what medications they're taking today. So next year might be different. The enrollment period goes from November through, or mid-October through mid-December for the following year. So patients are having to make those determinations on what prescription drug plan they're going to be on, and again, usually based on what they're taking right now and assuming they're going to take something similar next year. If drug companies start to change and now they're only allowing patients to use a generic versus the original one, costs could change there as well. So keeping that in mind, we just recommend patients work with a broker that can help them. It doesn't cost them anything to work with a broker, but allows them to get the best available information out there to find the best plan for them. The other thing to keep in mind, again, this is not something you're going to have to deal with all the time, but it's good for you to understand where our patients are coming from. In the Part D plan, when it comes to prescription drug coverage, there's a thing called the donut hole. And most patients that are in the Medicare plan understand what this is and try to stay away from that. What that means is once a patient has met their threshold of dollars for prescription for that year, they fall into what's called the donut hole. Once they get into the donut hole, the patient now has to pay for 100% of their prescription drugs until they come back out of the donut hole. So it's, if you think about it like a linear progression, if say your drug benefit is $10,000 to reach the donut hole and then $15,000 to now get out of it. So as long as the patient only needs about $10,000 worth of drug prescription for that year, then they should be fine. They probably won't fall into the donut hole. But if patients aren't paying attention to what medications they're taking, or they're all of a sudden have some diagnosis that puts them in, maybe cancer treatment or something like that, where now they're taking medications that are extremely expensive for them, they fall into the donut hole really early in the year. I've seen people fall into the donut hole as early as April or May of the year, and now they've got $5,000 that they have to try to come up with to get back out of the donut hole before they can have Medicare cover it again. So again, it's one of those things where I've had patients in the past tell me, yeah, I fell into the donut hole. I went to pick up my prescription drugs. I couldn't afford them, so I just picked up the cheapest one. So it's good to know if patients are telling you that, to make sure that they're talking to their doctor and or their pharmacist about that. I had specifically one patient that decided she wasn't going to take most of her medications. She just picked up the cheapest one because it was all she could afford. I told her to talk to her doctor about it. Sometimes doctors can come up with a better way, like maybe they can take them off one of the medications, or maybe the medication they decided not to take is the one that was helping them with any sort of side effects that they had with the other one, or vice versa. So making sure patients are talking to their doctor and letting them know about things like this when they decide they're not going to take them. And some drug prescription companies have the ability to help patients out, especially when they're in that donut hole, of doing something like maybe a $5 copay, or allowing them to get free prescriptions for a month or 3 months that helps cover them until they can get back out of that donut hole. So being mindful of when patients are saying this, making sure that they're talking to their doctor to make sure that they're on the proper medications, or to find if there's some other way that they can get through that time and take the appropriate medications. Okay, so Medicare coverage in various settings. We've talked about some of this throughout the semester, but just to make sure that we all have it all in one place, when it comes to acute care, Medicare reimburses by the inpatient prospective payment system or payment rate, IPPR. In the inpatient rehabilitation side, reimbursement is by prospective payment system. So when you do the initial evaluation, you're using your FEM score, and then PPS is then paying them and reimbursing facilities based on that. In skilled nursing facilities, it was reimbursed by prospective bundled payment previously, and that was using the RUG system, but like we talked about earlier, as of October 2019, that has now changed to the PDPM, and we're still seeing a lot of fallout for that. A lot of skilled nursing facilities in the area are stopping or getting rid of all of their PRN staff. A lot of PTAs are losing their jobs just because they don't need as many providers to provide the care now that they're moving into the PDPM model. There's still a lot that has to be learned from that. It's still really new in the system, and we have to see how that's all going to shake out. But right now, that's what corporations are doing, is just stopping the coverage of therapy staff that they have and utilizing what they do have to ensure they can get the coverage for their patients. Next thing is the outpatient therapy services. That's still paid under the Medicare physician fee schedule. In the future, they're looking at making changes, but right now that's how it's being paid out. Home health care services. Again, that was under the prospective payment system for any of the ones that fall under the Hospital Part A of Medicare. Hospital Part B is billed out as a physician fee schedule, but starting January 1 of 2020, they're switching that over to the PGPM, which is a different payment model, similar to the PDPM, but slightly different, and there's some new rules that are coming out about that. And every week there's new Medicare changes that are coming in regards to that. So if this is a field that you're going to be working in, just making sure that you're working with your management to understand how that works and how you need to be coding things differently than what we did before. Hospice care, that's paid for via a daily rate schedule that Medicare has laid out. And then community service prevention and wellness. Again, this is a great thing for PTs that we can provide prevention and wellness services under the Medicare guidelines. And just as a reminder, patients are assessed in their environment, skilled nursing facility by a minimum data set per the Medicare guidelines, and then home health with the OASIS that we've discussed earlier in the semester. So there is something that came out a few years ago called the medical home model, and that's something that is ever changing as well. Again, entrances are always trying to figure out how they can save money but provide the best cost-effective care for their patients. And so they put people into what they called a medical home model, and how they did that was they grouped patients with specific diagnosis into the categories, and they're followed by their healthcare provider. This is physician directed. The goal of this is to coordinate care and making sure that the patients are getting the care that they need. So a lot of different organizations use this when it comes to maybe their diabetic population. So maybe with their pediatric diabetic population, they're ensuring that all these patients every 6 months are seeing the doctor to make sure that their blood sugars are staying normal. And this can also be the geriatric population as well. It doesn't really matter, but when they have that specific diagnosis, like somebody that's diabetic, making sure that they're consistently taking their medications. Maybe they have a nurse or somebody on staff that's contacting the patients once a month to make sure that their blood sugars are staying within range, or that they know how to properly, use their blood glucose monitor. They know when to administer insulin. They know whether or not the patients are having issues getting insulin, because that is becoming a costly thing. And when it comes to the donut hole that we talked about earlier, if patients are choosing not to take and pick up their insulin because it's getting too expensive, what does that do for the patient then? They're going to get sick, they're going to have issues, they're going to have problems, they're probably going to end up in the hospital. So they're trying to keep people healthier long term by using something like a medical home model. Again, more of the cost control mechanisms. So with Medicare Part B, they have that annual payment cap. Since 1997 with the Balanced Budget Act, they used that to kind of neutralize the costs that were going out the door, and they put in place what was called a Medicare therapy cap. That has definitely changed over the years, but it is one thing that they used as a cost control mechanism. Another way that they are trying to control cost is using RACs, so Recovery Audit Contractors, and these people are sent out to investigate overpayments or possible errors. They get paid to recoup money from providers. It has changed a little bit over the last 5 years, but that is specifically how they get paid for the most part, is by finding errors in documentation. And thinking about when we do our documentation, how easy is it to make an error or an issue, a problem, making sure that, if you're not documenting appropriately every single visit, there is rationale or reason why auditors could come in and say, well, we're not going to pay for that. You said you did neuromuscular re-education, but then when I look at the flow sheet, you might have forgotten to put in all the neuromuscular exercises that you did with the patient that day, or any sort of activities that would fall under the neuromuscular column, and therefore we're not paying that out. And when they find errors like that, they'll start digging even further to see if they can find more errors that allow them to recoup more of their money. So into documentation, here's why it's really, really important to make sure that we're showing what we're doing is a skilled service and it's medically reasonable or necessary for the patient to improve. So per the benefit manual, and that would be the Medicare benefit manual, progress indicates that the care is effective in a rehabilitation of function. So that's what we have to keep trying to prove time and time again. A payer expects the documentation will reflect the need for skilled service and include information pertaining to the patient's progress. So just keep in mind how we document is really important and ties back to the reimbursement and how we get paid in each one of our settings. So again, instead of noting that somebody has fair plus strength for their quadriceps, which is not a bad thing to state, but if you can tie it back to the function of how that will impact the patient negatively if they don't reach that, or positively if they do, is really helpful in having insurance have a better idea of how that's going to benefit the patient. So like this, patient requires use of a standard cane on all surface, unable to climb stairs without a railing or minimal guarding of one person. That shows why working on strengthening of the quadriceps might be really important for this specific patient here. So just making sure that you're tying things together, painting a picture of what your patient looks like now, and how the benefit of your skilled intervention is going to help the patient be more independent, require less services, etc. into the future.